I think I am not able to go live.
आप OBS पे जाओ वापस।
स्टॉप स्ट्रीमिंग कर दो।
स्टॉप कर दी?
नहीं भी नहीं करी, कर दो स्टॉप। Hello everyone. Now I am audible and visible. Yes, so we will start. My apology for little bit technical hitch. Okay, no problem. So here is NEET PG top topics. Okay, whether we talk about syndromes or its metabolic disorder, or it's CHD, whether it's vitamin, or it's a torch group of infection, or it's immunization. These are evergreen topic. You find n number of question on Down syndrome, Turner, metabolic disease, Hurler, Hunter, alkaptonuria, Pompey's, CHD, TGA, TAPVC, vitamins, rickets, scurvy, full of questions, torch group of infection, immunization. These are very few topics which are known as top topic in pediatrics for NEET PG. Yes, myself, Dr. Sanjay Khatri, your pediatric educator, I will take you to these all topics to give you a hold how to proceed in these topics and how to make hold on your pediatrics. Something about Unacademy, unlock your potential. You will get 25% discount. Yes, 25%. Valid till 17th June. One day left. See the price, my friend. Don't miss this opportunity. Use the code Dr. Sanjay K. Now, NEET PG Vital. Join it. Feel the difference. All the Unacademy educator put their vast experience to make this video for you with the help of high quality technical team. You will love to watch this. So be there. And now scholarship test. Nothing to lose. It's my recommendation. Go for these type of test. Nothing to lose. Check your performance amongst others. Get chance to win prizes. Go for scholarship test. Now, question. Top topic. Yes. Question number one. Question number one. Mentally retarded 5-year-old boy found to have macroorchidism, large testes and large ear. Very common question. Very common question. What is this? This is Fragile X syndrome. Fragile X syndrome shows anticipation phenomena. What is this? Severity of disease increase with successive generation. If disease occur in grandfather, severity will more in father, even more in son. Severity increase with successive generation. Anticipation phenomena. It is due to triple codon transmission. Which triple codon? C, G, G at FMR1 gene. So these repeated with successive generation. In first generation, their number is 50. Second generation, maybe 200. Third generation, maybe 400. Fifth generation, maybe 600. So their number increased with successive generation. So severity also increased with successive generation. This is the classical history of Fragile X syndrome. Large testes, large ear. Simple one. Okay, few more. Answer this. Yes, Farman and Vikas D. Good. Answer this question. Initial laboratory studies to investigate a metabolic disease. What you need to know when your approach is for metabolic disease? Can you answer? Okay, we go to the text, then we again come to the question. Suppose a neonate comes to you with complaint of vomiting, dullness, convulsion. Vomiting, dullness, refusal to feed. First thing you will think, it's sepsis. No, septic screen negative, it's not sepsis. Why baby is dull? It is due to birth asphyxia. No, there is no history of birth asphyxia. Maybe hypoglycemia, but not respond to IV glucose. Neonate or infant, dull, refusal to feed, vomiting, convulsion. Sepsis rule out, asphyxia rule out, hypoglycemia rule out. Then you think it may be metabolic disease. There are hundreds of metabolic disease. Is there any algorithm? Yes. First we do ammonia. We check ammonia. Now two possibility. Either ammonia increase or ammonia will be normal. Now both the cases we do blood gas for pH. Blood gas for pH. Now we have specifically three subgroup. Ammonia increase, pH normal. It is urea cycle disorder. Ammonia normal, pH normal. It is amino acidopathy or galactosemia. Whatever the level of ammonia, but pH show acidosis, then it is organic acidemia. Listen, very simple. You need to check ammonia and pH. Ammonia normal, pH normal. Amino acidopathy or galactosemia. If ammonia increase but pH normal, then urea cycle disorder. Whatever the level of ammonia, if pH show acidosis, it is organic acidemia. Come to the question. Come to the question. So we need pH, bicarbonate and ammonia to investigate a metabolic disorder. What is normal blood pH? 7.35 to 7.40. If you find pH 7.1, 7.2, acidosis, it's organic acidemia. What is the normal level of ammonia in neonate? Less than 200 milligram percent is normal beyond neonatal period, beyond 28 days. It is less than 80 considered to be normal. Okay, suppose you are investigating and your urea will come, ammonia will come 1200, 1400. Yes, it is in urea cycle disorder. Ammonia will be more than 1000, more than 1000, more than 1000. Which amino acid used to decrease the ammonia level? Which amino acid? Question. Arginine. Arginine. Okay, when hyperammonemia is there, we use arginine, phenyl acetate or sodium benzoate to bring the ammonia level down. If it's not coming down, then we need to do the dialysis. So yes, good neonatal unit. You can't check ammonia everywhere. You need a proper lab for ammonia checkup. And those who are doing good work in neonatology, metabolic disorder, they have a good ABG machine to check pH and ammonia. So these two are the basic when you are investigate a metabolic disease. When you investigate a metabolic disease. Now answer this question. Read. First you read, then make your answer. One week old present with poor feeding, vomiting, lethargy, opisthotonous posturing. It may be meningitis, sepsis, clinical impression of meningitis, but cultures are negative, so it's not sepsis. Seizures not respond to IV glucose, so it's not hypoglycemia. pH 7.15, acidosis. ammonia normal. If pH is acidic 7.15, answer is organic acidemia. Same question, if they will give pH 7.35, ammonia level is more than 1200 milligram per dl, ammonia increase, then it will be urea cycle disorder. So approach to metabolic disorder, how you need to interpret it by ammonia and pH, one of the important topic for NEET PG. So it's very clear na what basic things we need. Ammonia, pH, bicarbonate. And what is approach? Ammonia normal, pH normal. Immunocytopathy, galactosemia. Ammonia increase, pH normal, urea cycle disorder. Whatever the level of ammonia, pH acidosis, organic acidemia. Clear? So we move one step further. One step further. Yes, you people are enjoying. One step further. Follow this. If there is acidosis, pH is 7.1, 7.15, then you need to check the ketones. If there is no ketones in urine, pH is acidic, but no ketone in urine, you are dealing with fatty acid oxidation disorder. Fatty acid oxidation disorder. But when pH is acidic, ketones has to be there. Then you need to look for skin rash. Rash is there, rash is there. You are dealing with multiple carboxylase deficiency. Multiple carboxylase deficiency. This question was asked in NEET PG 2 times. Neonate comes with this pH 7.15, having eczematoid rash all over body. Rash, multiple carboxylase deficiency. If rash not there, you check for any order. If urinary show particular order, maple syrup order, maple syrup urine disease, sweetie feet order, isovaleric acidemia, but no order, it is classical organic acidemia. Simple, very simple. See, pH is acidic, acidosis. Hold on. Examiner say no ketones in urine, fatty acid oxidation disorder. Examiner say ketones present, but rash is also there, multiple carboxylase deficiency. pH acidic, no rash, but particular order, that disease. Nothing is mentioning about ketones, nothing is mentioning about rash, nothing is mentioning about any order. So it's simple, organic acidemia. So it is approach to metabolic disorder. Approach to metabolic disorder. I hope I am clear in this. You need to concentrate ammonia and pH, three subgroup. Further, if it is acidosis, look, ketones are not there, fatty acid oxidation. Rash is there, multiple carboxylase deficiency. Nothing mentioning about rash or order, is it organic acidemia. Approach to metabolic disorder. Okay, am I clear? Shall I move? Answer. Simplest but evergreen question. Which of the following biochemical marker used for antenatal screening of Down syndrome during first trimester? So nowadays, antenatal diagnosis, everybody has one or two kids. Nobody wants, nobody wants their baby is having Down syndrome. So why this? We can diagnose antenatally with lot of biochemical tests and sonography. We can detect antenatally when mother is pregnant, this baby is going to be Down syndrome. So we can avoid actually Down syndrome. So what are the things? Down syndrome, antenatal diagnosis depend upon biochemical and USG finding. Biochemical test generally be done in second trimester, 16 to 18 week. 16 to 18 week. Alpha fetoprotein decrease. Estriol decrease. HCG increase. All three known as triple test. Triple test. Triple test used for screening of Down syndrome. What is the fourth component recently added in this? That is inhibin A. If you add inhibin A in triple test, that become quadruple test. That become quadruple test. This we diagnosed in second trimester. But family is so much worried. Maybe mother is of more age. They are worried, or their first baby is already Down syndrome. They don't want to continue the pregnancy if second baby is also Down syndrome. For that, they need to check the biochemical marker. What biochemical marker used in the antenatal diagnosis of Down syndrome during first trimester? PAPPA, pregnancy associated placental protein A. Pregnancy associated placental protein A decrease and beta HCG increase. These two markers used in the diagnosis of Down syndrome during first trimester. PAPPA and HCG. These two are used in the diagnosis of Down syndrome during first trimester. During first trimester. All four can be used in diagnosis of Down syndrome in second trimester. These are the sonography signs. When mother goes for antenatal screening of anomaly scan, baby IUGR, ventriculomegaly, choroid plexus cyst, cystic hygroma. Other feature, hypoplastic nasal bone, nuchal thickness increase, echogenic focus in heart. Endocardial cushion defect in the heart, double bubble sign, short humerus, short femur, two vessel umbilical cord. These all are the soft sign of Down syndrome. See their report. Down syndrome is the commonest chromosomal anomaly. When mother is going for anomaly scan, people who are doing this, they are radiologists, they are genetic people, so they diagnose it, read their report. No ventriculomegaly seen, no choroid plexus cyst seen, no cystic hygroma seen. Nasal bone density this much normal, knuckle fold thickness this much normal. Heart fourth chamber of the heart clearly seen. No double bubble sign. Humerus length this, femur length this, three vessel umbilical cord. It means they look for it. They have looked, and so many MCQs are there. Choroid plexus cyst in a fetus suggestive of which syndrome? Down syndrome. Cystic hygroma, Down syndrome. Endocardial cushion defect, Down syndrome. So yes, these are sonography. How much it will take? Sonography they will do in 15 minutes, and biochemical test 2 ml blood, 1 minute job, report will come next day. If sonography normal, biochemical marker normal, 99% baby will not have Down syndrome. So go for it. Nobody wants. Generally, these tests preferable done in females whose age is more than 35 or first baby born with Down syndrome. But current era, nobody want to take risk. Go for this. Do anomaly scan, biochemical marker, and rule out Down syndrome. There are MCQs, so many time, so many MCQ. Answer this question. Newborn, bilateral cataract, microphthalmia, IUGR, hemorrhagic skin lesion is scattered throughout the body. What this skin lesion known as? Blue berry muffin lesion. Blueberry muffin lesion and short systolic murmur. So murmur is there, cataract is there. What is this? Answer? Yes, it is congenital rubella syndrome. NEET PG, torch, very important topic. Remember one by one. Triad of rubella, deafness, cataract, CHD. Which CHD? PDA and PS. Systolic murmur is of PS. PDA and PS. Triad of rubella. So many questions. Last year, INI-CET, this question was there. Okay. Toxoplasmosis triad. Chorioretinitis. Diffuse cerebral calcification. Hydrocephalus. Triad of toxo. Congenital varicella syndrome. It's not described as a triad, but two classical feature: limb hypoplasia, cerebellar hypoplasia. Limb hypoplasia, cerebellar hypoplasia. And CMV, periventricular calcification. Toxo, you have diffuse cerebral calcification. CMV, periventricular calcification. My friend, remember the thing first. It's not essential you always have a long history based question. Last INI-CET exam, 30 questions are one word out of 200. One word. Okay, so periventricular calcification is characteristic of CMV infection. These you know, these all are basic. Something more, something advanced. If mother is having parvovirus infection, baby will have non-immune hydrops fetalis. If mother is having HIV, baby will have severe thrush, failure to thrive, calcification of basal ganglia. If mother is having Zika virus infection, what manifestation occur in the baby? Microcephaly, lysencephaly, cerebellar hypoplasia, subcortical calcification, and ocular finding. What is lysencephaly? Lysencephaly is smooth brain. Normal brain is like this. You have gyri and sulci. This is normal brain. But lysencephaly brain is smooth brain. Agyria. Agyria. Smooth brain. Probable question. A baby born with lysencephaly, mother is suspecting which infection in pregnancy? It's Zika virus infection. Clear, na? Clear. So you find so many questions in NEET PG like this. Try to read the question and give the answer. Neonate has rudimentary digits, cortical atrophy, cerebellar hypoplasia, scarred skin lesion on limb, rudimentary digit, limb hypoplasia, digit hypoplasia, cerebellar hypoplasia. It is characteristic of, yes, Bashir, it is characteristic of chickenpox embryopathy. So torch, there are so many questions. They started from triad of rubella, triad of toxo, classical calcification finding, diffuse cerebral in toxo, periventricular in CMV, basal ganglia calcification in HIV, subcortical calcification in Zika virus. So these all are very important, very important. Okay, answer this question. I am holding brainstorming question, INI-CET type question. Match the following regarding torch, which is correct. Take your time, my friend. That's why we are reading. Na? You have concept of torch. This is application based question in front of you. Try to choose the right answer. Yes, Vikas, Bashir, Farman, Ronak. Answer it. Bashir is answering C. Let's see. Toxoplasmosis periventricular calcification is not right. Congenital varicella limb hypoplasia, true. Zika virus lysencephaly, true. CMV cataract, no. Rubella hearing loss, true. So correct answer will be 2, 3 and 5. 2, 3 and 5. Bashir is right. So this is the way. First we read the torch, then we read the common points, then some tricky question, history based question, match the following question. Topic is finished. So if you remember this much thing about torch, topic has been done. This is the question. Torch group of infection. I hope you all are clear in this. Answer this question. 7-month-old child having loss of neck control, exaggerated startle response to noise, macrocephaly, cherry red spot in eye. You are suspecting which? Yes, it is Tay-Sachs disease. How you remember? Number one, it is characterized by microcephaly. Number two, cherry red spot in eye. Number three, neurodevelopmental regression. The milestone which child achieved now regressing. Suppose child able to sit, now not able to sit. Child able to stand, now not able to stand. Child able to hold the neck, now not able to hold the neck. And fourth and classical, which really clinch the diagnosis, it is exaggerated startle response. Exaggerated startle response to noise. If you clap, maybe do like this. This is exaggerated startle response. Exaggerated startle response. The point number fifth, classical MCQ of Tay-Sachs disease. In Tay-Sachs, no hepatosplenomegaly. No hepatosplenomegaly. And number six, there is no treatment of Tay-Sachs. No enzyme replacement therapy. 6 point. So Tay-Sachs is due to deficiency of 6 hexa aminodase A. Which enzyme deficient in this condition? Hexaminodase A. These are the 6 point of Tay-Sachs disease. Exaggerated startle response is a feature of Tay-Sachs disease. No hepatosplenomegaly, Tay-Sachs disease. Clear? So many times. Answer this question. Yes, Vikas and Bashir, right? Others should also answer, na? Interact. Try to learn and interact. 4-year-old blue-eyed white female manifest malar flush, mild mental retardation, subluxation of ocular lens, and marfanoid-like features. All features are marfanoid, but one word is written, that is mental retardation. In Marfan syndrome, IQ is normal. In Marfan syndrome, IQ is normal. So it can't be Marfan. So it can't be Marfan. So what is this? This is homocystinuria. So one point about homocystinuria, it is autosomal recessive disorder. Second point, Marfan-like feature, like in our question, plus mental retardation. Plus mental retardation. Prone for thromboembolic episode slash stroke. In medicine, you read the causes of stroke. Metabolic, number one is homocystinuria. Surgery, deep vein thrombosis causes. Metabolic, number one, homocystinuria. Pediatrics, which aminoacidopathy leads to stroke? It is homocystinuria. A child comes with hemiplegia, unexplained, unexpected, we check the homocysteine level. Homocystinuria, thromboembolic episode slash stroke, and one universal MCQ. It is pyridoxine dependent condition. It is B6 dependent condition. Yes, yes, yes. Life is great moment. Downward and inward subluxation. You can differentiate from Marfan and homocystinuria by subluxation of lens. But yeah, the most important, mental retardation in homocystinuria. Marfan, IQ is normal. Marfan, IQ is normal. So clear. Tay-Sachs disease, homocystinuria. See this question. Just read this question. A 5-year-old male, developmental delay brought with frequent squinting, bilateral lens subluxation. Ophthalmologist can tell when they see the lens which direction it is subluxated, but grossly lens is subluxated and developmental delay, so it is homocystinuria. Now after 4 years he died of massive stroke. Yes, strokes are common. Autopsy revealed middle cerebral artery thrombosis, old renal infarct, stroke thrombosis common, and it is disease course can be modified by supplement of pyridoxine B6. It is B6 dependent condition. Typical NEET PG question. History based integrated question. Clinical history with vitamins. Got it? Universal question. 3 times in last 5 years NEET PG this question was there. I want answer from your side. Infant brought to the hospital, her wet diaper turned black when exposed to air. That's all. Exposed to air. What is this? It is alkaptonuria. When you read alkaptonuria, tyrosine, through its subsequent metabolites, convert into homogentisic acid, and homogentisic acid, in the presence of homogentisic acid oxidase, convert into fumaric acid and malic acid. Now if homogentisic acid oxidase is absent, is not there, what happen? Homogentisic acid will accumulate in the body and condition known as alkaptonuria. Condition known as alkaptonuria. It is characterized by two features. Urine turn black when exposed to air in infant, older children, onchronosis, that is deposition of black pigment in various body tissue, and arthritis. And arthritis. Urine turn black when exposed to air. Urine turn black when exposed to air. Deposition of black pigment in various body tissue, onchronosis. Onchronosis. Alkaptonuria is due to deficiency of homogentisic acid oxidase enzyme. Remember this feature. Remember this feature. Yes, this is alkaptonuria. Some question about vaccination. Typical question. Which one of the following statement is correct about intradermal fraction inactivated polio vaccine in respect to IPV? Now, one is national immunization schedule. Another is IAP, Indian Academy of Pediatrics schedule. What national schedule say? The schedule followed at all government hospital, all PSC, all vaccines are free. Birth 6 week, 10 week, 14 week. Birth we have OPV 0 dose. 6 week OPV 1, OPV 2, OPV3. National schedule say this. What IAP follow? Birth, OPV 0. Then 6 week, 10 week, 14 week. IPV, injectable polio vaccine. Less chance of paralytic polio or no chance of paralytic polio. Then national body think, yes, IPV is must. So they also include IPV in national schedule, but they continue oral polio. So where they put IPV, not giving the full dose of IPV, they give 6 week fractionated IPV vaccine and 14th week fractionated IPV vaccine. What is fractionated? IPV is given by IM. Dose is IM. Dose is 0.5 ml. Fractionated polio is 1/5 of IPV. That is 0.1 ml. And it is given by intradermal route. So many time question come. What is fractionated IPV? It is 1/5 of IM dose of IPV. Clear? Second time they ask when fractionated IPV is given in national schedule. First dose at 6 week, second dose at 14 week. 6 week, 14 week. Vaccination started. Key question on vaccination. Current one, fractionated IPV. Clear? Now, this question, UPSC, last year this question was asked. Which vaccine stored in the top rank of main refrigerator compartment at temperature 4 to 10 degrees centigrade? Generally, you have a freezer. This is freezer. This is first rack. This is second rack. This is third rack. And this is the door of the fridge. Door, generally, we not keep any vaccine. Freezer, we keep OPV. First rank, generally MMR, measles or BCG commonly, and third rank is for diluent. But yes, few other vaccine we also keep in the first rack, but second rack is mainly for the vaccine whose spelling comes word T. There is hepatitis, DPT, TT, rotavirus, every vaccine is in rack 2. So here they are asking top rank. So answer would be BCG, measles and MMR. Clear? BCG, measles and MMR. See more clearly. This is OPV we keep in the freezer. Top we keep BCG and measles or MMR. Door, no vaccine should be kept in the door. Diluent for lower rank. Okay. So top for BCG, measles, MMR. Listen carefully. Cold chain. Place measles, MMR, BCG. This sure you can put yellow fever, Japanese encephalitis and meningococcal vaccine on the top shelf. Also on the top shelf. So other than measles, MMR and BCG, yellow fever, Japanese encephalitis and meningococcal vaccine also on the top rank. DPT, T is coming. T, 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 hepatitis, always middle shelf. Hib, rotavirus, middle shelf. So clear na? Measles, MMR and BCG top shelf. With them you can put yellow fever, Japanese encephalitis and meningococcal. Middle for all other vaccine and base for diluent. So remember, like top shelf, refrigerator OPV, top shelf, MMR, measles, BCG, yellow fever, Japanese encephalitis and meningococcal vaccine. Okay, middle, all other vaccine, base, diluent. So you will not face any problem in this type of question. Clear? Clear? One more question on vaccination in current exam. Answer this question. I love to see who can answer this question. Who can answer this question? ANM conduct vaccination camp in village. She received open vial of MR and pentavalent vaccine. When she is checking the vaccination box, she find MR vial is open. 5 doses are there, 2 given, something is remaining. Same, pentavalent also open. So is there any policy if somebody find open vial? Yes. This is known as open vial policy. Applicable to hepatitis, DPT, TT, OPV, IPV, Hib containing pentavalent vaccine and pneumococcal conjugate vaccine. So if you find open vial of this with proper precaution, you can use it. Open vial. Hepatitis, 10 doses are there. In first camp, 8 children came. We given hepatitis. 2 remaining can be used in next day camp. Pentavalent, 10 doses are there. 7 is given. 3 we can use in the next camp. But not applicable to. Once you open the BCG, should be consumed less than 3 hours. You can't keep BCG open and give next day. MMR and measles, if you give, it lead to toxic shock syndrome. Japanese encephalitis and rotavirus vaccine, not applicable to. Not applicable to. Remember this thing. Remember, not applicable to. So, pentavalent can be used. MR, discarded. So, use penta, discard MR. Open vial policy, cold chain, fractionated polio. There are many. But yeah, these are some top topic in NEET PG. You should know this. Answer this question. We have read alkaptonuria, homocystinuria. This is one more. 4-month girl, mild respiratory distress, on examination large tongue, hepatomegaly, floppy limb, X-ray show cardiomegaly, ECG show short PR interval. Normally this is P and this is R and this is T. You can appreciate P and R. But what happened in Pompeii is as soon as P finish, R start. Short PR interval. Short PR interval. It is classical of Pompey's disease. Short PR interval. Classical finding. Remember, floppy, large tongue, cardiomegaly, ECG show short PR interval. 2 times they ask which enzyme deficiency is there in Pompey's. Acid maltase. Floppy baby, large tongue, cardiomyopathy. ECG show short PR interval. Remember, these are top topic. Pompey's, alkaptonuria, homocystinuria, you find everywhere in the exam. Approach to metabolic disorder. These are considered as evergreen topics. Am I clear? Tay-Sachs, answer this. Exclusively breastfeed baby predisposed to develop. If you know this, you can answer, else you will not able to answer. Breastfeed, yes, breastfeed baby leads to hemorrhagic disease of newborn. You prick, site bleed. You put cannula, that site bleed. Sometime ICH, hemorrhagic disease of newborn. It is due to deficiency of vitamin K. HDN, hemorrhagic disease of newborn. It is due to deficiency of vitamin K. Early, within 24 hours. Mother is taken some drug which interfere with vitamin K function. What drug mother is taking? Like phenobarbital or warfarin. Mother is on those drug which interfere with vitamin K function. Bleeding occur within 24 hours. Classical. Baby is on breastfeed. Baby is on breastfeed. Not receive vitamin K at the birth. So prone to develop hemorrhagic disease of newborn. Why? Breast milk contain very less vitamin K. That's why two practice done in pediatrics. As soon as baby born, give vitamin K. So early will not occur. Classic will not occur. Give vitamin K, then breastfeed the baby. Resuscitation protocol, we give vitamin K at the first hour, vitamin K. Then late, 2 to 16 week, baby who are on prolonged antibiotic therapy, vitamin K synthesized in the gut, antibiotic destroy the gut flora. So what happened? Baby is on prolonged antibiotic therapy, gut flora damage, vitamin K deficiency occur. So that's the common protocol in all nurseries and ward in pediatric practice. If child receive antibiotic for 3 week, 4 week, 6 week, based on whether child is having sepsis, pneumonia, meningitis, osteomyelitis, every 7th day should receive vitamin K. So hemorrhagic disease of newborn, early, classical and late. Early, classical and late. Hemorrhagic disease of newborn occur in breastfeed babies. Why? Because breastfeed contain very less vitamin K. Answer this question. Infants of diabetic mother, weight 4.4 kg, presented with seizures. Now mother is having diabetes. Excessive glucose from mother goes to baby. Baby Iceland of Langerhans are normal, so they synthesize insulin, more and more insulin, more and more insulin. Now cord is cut. Cord is cut. Excessive supply of glucose is blocked, but insulin is high in the baby. So what happened? What happened? Infant of diabetic mother are prone to develop hypoglycemia. Why? Because insulin is more. That's the reason. That's the reason for seizure. So infant of diabetic mother, weight 4.4 kg. Now why weight is more? Insulin and insulin like growth factor responsible for growth of the baby. So insulin is more, weight of the baby is more. So baby will have macrosomia or LGA baby. Insulin more, insulin decrease the surfactant. So infant of diabetic mother are prone to develop HMD. Prone to develop HMD. See here. Complication occur in infant of diabetic mother. Universal topic, universal questions. Hypoglycemia, hypocalcemia, polycythemia, hyperbilirubinemia. Hyaline membrane disease, neural tube defect, sacral agenesis, also known as caudal regression syndrome. It is most specific disorder of infant of diabetic mother. If baby mother is having diabetes, definitely high chance of cardiac problem. VSD, TGA, asymmetrical hypertrophy of interventricular septum, renal vein thrombosis, lazy left colon syndrome, hairy pinna, macrosomia. Hairy pinna, macrosomia. Clear? Clear? These are the complication occur in infant of diabetic mother, and you find day and night question. All are the complication occur in infant born to diabetic mother. Renal vein thrombosis, hyperbilirubinemia, VSD, hepatitis. Hepatitis is not there. Hepatitis is not there. So complication occur in infant of diabetic mother. You should know. You should know. Clear? Clear? Answer this question. 18-year male child presented with complaint of delayed onset of puberty. On examination, he is tall, underweight child, large arm span and small testes. History of antisocial behavior during school days. It is Klinefelter syndrome, XXY. One X is extra. Individual is tall, underweight, thin male child. So they are not able to diagnose easily. Individual is tall, underweight, thin male child having small testes. So they presented to pediatrician or endocrinologist with the complaint of delayed onset of puberty. But this syndrome can be identified in early childhood in a child who have antisocial behavior in school days. Either they are very aggressive, their behavior is inappropriate for their age. Maar dunga, jala dunga, kaat dunga, like this a child can speak. 10-year 11-year old child, antisocial behavior during school days, high suspicion of Klinefelter syndrome. And this is the classical history. NEET PG has a history of 2 questions from Turner syndrome in a same exam, 2 questions for Down syndrome in a same exam. This may be your turn. 2 questions from Klinefelter syndrome in a same exam. See, answer this question. Answer this question. 10-year-old female child presented with short stature, webbing of neck, cubitus valgus. Oh ho ho, this is Turner syndrome. Hold on. Read question carefully. Her chromosomal study shows normal karyotype. But in Turner, karyotype is 45X0. It can't be Turner. Feature of Turner. Feature of Turner, but normal karyotype. Feature of Turner, but normal karyotype. It is Noonan syndrome. It is Noonan syndrome. My question to you, Vikas, Bashir, Prajapati, which is the commonest heart defect in Noonan syndrome? Which is the commonest heart defect in Noonan syndrome? Udashri, Farman, anybody can answer. Noonan syndrome, commonest heart defect in Noonan syndrome. It is pulmonary stenosis. It is pulmonary stenosis. See, this is about Turner syndrome. You can see cubitus valgus. Webbing of neck, coarctation of aorta, bicuspid aortic wall, horseshoe kidney, fatty streak ovary. Classical feature. See the image and see this image. Classical feature of Turner. What you are anticipating? Dr. Anam. Yes, it is stenosis, pulmonary stenosis. Very good, Anam. It is common start defect in the Noonan syndrome, pulmonary stenosis. What you are seeing in this picture, this is first finger, second, third, fourth. You can see fourth finger is short. You can see why? Because there is short fourth metacarpal. This is the classical feature of Turner syndrome. If you can see your fingers, na? If you can see your fingers, fourth finger is little bit higher than little finger. But here, both are almost at the same level. Short fourth metacarpal is a feature of Turner syndrome. Answer this question. Child having microcephaly, small ear, polydactyly, cleft lip, cleft palate. You can't diagnose. These are non-specific features. Cleft lip, cleft palate, small ear can be present in any child. But the classical feature which point towards the diagnosis is scalp defect, also known as aplasia cutis congenita. Aplasia cutis congenita, scalp defect. Aplasia cutis congenita is a feature of Patau syndrome. See, Patau trisomy 13, Edward trisomy 18. There are so many lists to remember these feature, but classical 4 feature of Patau you remember. Not a single MCQ will be wrong. Patau patient, aplasia cutis congenita, scalp defect. What is this? I will show you. This is on the scalp. Round portion, hair and skin is absent. Aplasia cutis congenita. Holoprosencephaly, this is neuronal migration defect. Cleft in the forebrain. Microphthalmia polydactyly is a feature of Patau. Edward, trisomies are hypotonic, but Edward patients are hypertonic. Overlapping of finger, you find hand like this. Overlapping of finger is a classical feature of Edward syndrome. Overlapping of finger, classical feature of Edward syndrome, and prominent occiput. See, overlapping of finger, Edward. Aplasia cutis congenita, Patau. This is such a classical feature. When radiologists do the anomaly scan, if they find the fetus hand picture like this, they write in their report, possibility of Edward cannot be ruled out. They usually take a picture of hand like this, but overlapping of finger, point out it's going to be Edward syndrome. Answer this question. Which of the following is true regarding Klinefelter syndrome? Associated with, which of the following is true? Short stature, overweight? No, they are tall and they are underweight. Advanced paternal age? No, advanced paternal age is associated with Marfan syndrome. Increased incidence of subluxation of lens? No, this is again a feature of Marfan syndrome. Klinefelter syndrome, increased risk of breast cancer. This is true. A is right, Bashir is right. Answer this question. You are seeing a 2-week-old child trisomy 21 in your OPD. Parents are asking for medical problem. Their child will need to be evaluated or screened. They know it's a Down syndrome. So parents come to you, doctor, we know it's Down syndrome, but what are the problems our baby have? What are the preventable problems? So they can want to know everything. So you can tell them Down syndrome patient having risk for leukemia. They have atlantoaxial instability, and you check TSH of TSH T3 T4 in all the patients because 30% of them have hypothyroidism. These three are the possibility in Down syndrome. Yes, atlantoaxial instability is the feature of Down syndrome. Coarctation of aorta is not. Coarctation of aorta is a feature of Turner syndrome. Turner syndrome. So, at the risk of all of the following condition except coarctation of aorta. Clear? So, most important top topic in NEET PG, we cover torch, syndromes, Turner, Klinefelter, Edward, Patau, Down, classical question, metabolic diseases, Tay-Sachs, alkaptonuria, homocystinuria, Pompe's disease, key question on vaccination, infant of diabetic mother, hemorrhagic disease of newborn. These are the top topics. Yes. So keep reading. I will be there to guide you, coming with some more classes of top topic in NEET PG. So our aim, let's crack it. Myself, Dr. Sanjay Khatri, keep reading, keep reading, keep reading. Only one motive. Okay. Keep reading and keep learning. If you like this class, share with your colleagues, your junior, your senior, so they can also be benefited. Hope to see you in future classes of Unacademy YouTube platform. God bless you all. Thank you. Bye bye. Thank you. Bye bye.